And now it really is my pleasure to introduce our next speaker, who is Dr. Larry Shulman. He is my colleague. He serves as the Deputy Director of the Abramson Cancer Center here at Penn. He's an expert in many of these areas, and he's going to share with us tonight national efforts that are looking at the impact of COVID on cancer. Thank you so much, Larry.
Thank you very much, Lynn, and thank you all for having me this evening. Can you hear me okay? Good.
Yes.
So I wanted to talk a little bit about the national response, and I think the reason that this is important to think about is we need to learn, like all the other things that you've heard about this evening, what we've done well and what we could probably do better. And, you know, we've done some well, and there are some areas of improvement. You've heard a lot about what we've learned over the last 8 or 9 months, but I think it's important to go back in your mind and think about where we were in March. And what did we know about COVID? What did we know about infection in cancer patients? And how is it going to affect the patients who had cancer but didn't have COVID? And the answer is we really knew little to nothing. We really had no idea what was happening, how this was going to affect our healthcare systems, and how we were going to best manage our patients. And we're in a much better place now, but just think back to what we were all thinking about back then. Papers like this came out, and this came out in April. And this is from China. And these were studies that were observational. They were small numbers. They were anecdotal. We learned a little bit from them, but we didn't learn a lot. And Charu and others have gone through what we've learned. And I'm not going to cover that again. But again, you have to remember back in days when we were really much less informed than we are now. So what happened? We did do a lot of things well, and you've heard a little bit about them. We did form consortiums, the NCI, the cooperative groups. You've heard about the CCC-19 study, ASCO, ASH, the American College of Surgeons, all turned around and formed registries that looked at the effect of COVID-19 infection on our cancer patients. But I think one thing to think about, as Lynn and others have talked about, is the majority of our cancer patients were not infected, but they were affected by what was going on in our healthcare system, and we needed to concentrate on them as well. And there was much less of an effort nationally and internationally to understand what the effects of the pandemic were on screening, on patients who were diagnosed with cancer, and so on. We didn't do quite as well there. Dr. Fauci mentioned this study that Ned Sharpless, our NCI director, published in Science earlier in the year, which hypothesized that there would be excess deaths from colorectal and breast cancer over the next decade due to delays in diagnosis and delays in treatment. And this is a pretty scary set of numbers. And though it's a hypothetical construct, it was important for us to start thinking very hard about what the effects of the pandemic were on our cancer care overall. One of the first groups to really think about this was Cancer Care Ontario. They're a very organized and very quality-driven group, and they published a pandemic planning guide for care of patients with cancer, actually in mid-March. While we were just starting to think about things in this country. And they developed a priority scheme, 3 layers of priority. Priority A, which was critical, requiring immediate care. Priority B, where some delay or altered care could be undertaken without compromising overall survival. And priority C, where patients could in fact have delayed care without compromising their ultimate outcome. And many of us around the US use this priority scheme to develop pathways on how best to care for our patients in the context of what was going on in your local environment, the infection burden, and the stress on hospital resources. Our professional organizations did rapidly come together, and these were a group of organizations that traditionally didn't work all that well together, and they're listed here. But the professional societies, the Commission on Cancer, NCCN, and countless cancer programs, including Penn and others, rapidly came together to try to figure out what the best way forward was in managing our patients. We developed guidance documents, and I'll show you one example of that in a minute. And we held webinars, often put together within 72 hours. And some of the webinars that I and others participated in spite of the fact that they were only advertised for 48 to 72 hours, had greater than 1,000 participants. So people were clearly looking for guidance from the national organizations. We had individual programs like the University of Chicago, who partnered with the American College of Surgeons and developed a medical necessity time-sensitive prioritization scheme for surgery with the scoring system that looked at the procedure score, what was involved in hospital resources, what the urgency of the disease was, and what the patient status was. And this system was used at Penn and many other institutions, rapidly adopted and extremely helpful. This is just an example of some of the webinars that we were running through the American College of Surgeons and the Commission on Cancer. These were occurring in late March. And again, these were heavily subscribed, often with more than 1,000 participants, again, put together very quickly, advertised very widely. We had a number of the societies that came together with disease-specific recommendations. This was the consortium that I was part of that included the American Society of Breast Surgeons, NAPBC, the NCCN, Commission on Cancer, and the American College of Radiology. And we held webinars and we published papers, again, giving guidance for how to prioritize our breast cancer patients and manage them through the stress of the pandemic, the infection risks, the restriction in hospital resources, OR time, and so on. It's, I think, worthwhile to note, if you look down at the lower left-hand part of the slide, we submitted this for publication on April 8th. It was accepted by the journal 2 days later and published online 3 or 4 days after that. These were very rapid turnaround times because people really needed to have guidance on how to manage their patients. The NCCN, as you know, is a consortium of 30 academic cancer centers in the US. We formed the Best Practices Committee COVID Task Force. We met virtually, obviously, weekly and shared information. And from my point of view, this was one of the more helpful forums that I participated in because very rapidly we exchanged information about how we were managing the COVID pandemic and our cancer patients across many of our major institutions around the country. We put this information together and published it. This is one example of one of our publications that came out in May. And again, people coming together, working hard together, and learning. So what are the lessons learned? We came together, I think, quickly as a profession and put aside differences and rivalries between professional organizations. But American medicine still remains somewhat fractured and siloed, and the approaches were not consistent across the whole country. We learned that our national clinical data systems were woefully inadequate to optimally meet the needs of a crisis such as the COVID pandemic. What did we really need? We needed a way to analyze the data live time, real time, throughout the country to better understand what was happening not only to our COVID infected patients, but equally importantly to our patients who were not COVID infected, but were having impacts on their care. And we needed to learn from this experience to improve both standard of care and crisis care. I'm hoping that I never see anything like this again in my profession. But as Lynn mentioned, we're not through this yet. We don't know whether there's going to be a second wave. We don't know what's in our future. We need to learn from this experience to carry us forward better the next time we're confronted with something like this. I just want to mention, and other people have mentioned this as well, the physicians and nurses, the healthcare providers in the front line were amazing. While we were in the background trying to give advice, there were countless people in the front lines caring for our patients. The national organizations did put differences aside, and I've never seen the degree of cooperation between them as we've seen recently. And obviously the patients worked with us during these unimaginable times. And I just wanted to also say, and other people have mentioned this, Dr. Fauci has been true leader in this, has shown what leadership is and what wisdom is, and has given us incredible guidance. So thank you very much